Okay, good afternoon, everyone. My name is Yahweh Song. I'm a project manager with the Community Outreach and Engagement team at the Sidney Kimmel Cancer Center. It is my distinct honor today to welcome you to our second conversation about cancer, recovery, research, and reducing your risk. Our topic today will be skin cancer, and we will cover information on skin cancer screening, diagnosis, treatment, and resources. We are joined today by medical experts from the Sidney Kimmel Cancer Center, the Cancer Support Community of Greater Philadelphia, and the skin cancer survivors. As our panelists sharing their knowledge and experience, please do not hesitate to ask them questions, and you may leave your questions in the Facebook comments. We will try our best to answer all your questions during our live events today. And to start, we would like to first introduce our amazing panelists. We will start with Dr. Nick Bart. Could you please just introduce yourself to our audience?
Good afternoon. Thank you, Yahweh. I'm Neda Nichbacht. I am a dermatologist and I am a faculty member here at Thomas Jefferson University. I am interested in cutaneous oncology, so I see patients with skin cancer. And also I run a research program that is focused on skin cancer here at Jefferson.
Thank you, Dr. Nick Bart. Dr. Jackson?
Hi, thank you. I'm Dr. Jackson. I am a dermatologist, so I work in the same department as Dr. Nickbach. I'm also a Mohs surgeon, so I both see patients in the general dermatology clinic and diagnose skin cancer, and then I'm also do a lot of skin cancer removals and reconstructive surgeries. I also have a very special interest in patients who are at high risk for cutaneous malignancies.
Thank you, Dr. Jackson. Dr. Cedar?
Hi, everyone. My name is Rena Cedar. I'm one of the medical oncologists at the Sidney Kimmel Cancer Center at Jefferson. My focus is primarily melanoma, both skin and eye melanoma, but I do see other advanced skin cancers as well.
Thank you. Kelly, would you like to introduce yourself?
Hi, everyone. I'm Kelly Harris. I'm the CEO at Cancer Support Community Greater Philadelphia. Our organization provides a comprehensive program of cancer support for cancer patients and their families around the Philadelphia area.
Welcome. Anne-Marie?
Hi, my name is Anne-Marie, and I am a cancer survivor. I was diagnosed with melanoma in 2019 and have gone through the Kimmel Cancer Center for treatment and thriving today. Thank you.
Thank you. And Steve? Steve, can you unmute yourself, please?
Sorry. Hi, I'm Steve. I have a long history of skin cancers going back probably 35 or more years, probably as a result of many years in the sun, on the beach, much of it before there were any lotions with sunblocks available, and it's an ongoing process for me.
Thank you, Steve. And thank you, everyone, for your introduction. And for people just joining our Facebook Live, we are talking about skin cancer today, and we have amazing panelists here with medical experts, support centers, as well as our skin cancer survivors. And to start our conversation about skin cancer, we would like to first talk about what is skin cancer and how you get diagnosed. Dr. Nick Bart, would you like to start?
Great. Yes. We prepared some slides so that we have a visual component, but let's make sure that everyone feels free to ask questions, and hopefully we keep this as a conversation moving forward, and we'll be happy to address any questions that the audience may have. Right. So to answer what skin cancer is, I think it's useful for us to think about what skin is. So the largest organ of our body that protects us from the environment, bacteria, viruses, and other things. And the skin has many different components, or what we call cells. So an analogy is like you have a big garden in our skin. There are different plants in it, different cells. So if a weed takes over, that's very similar to when you have cancer. So out of control growth of these different cells can cause different skin cancers. And because we have so many of them, we may have many different types of skin cancer. Now, the most common type of skin cancer is the out of control growth of these components that are on the very top, but right here at the baseline. So this is called basal cell carcinoma. Looks a lot of times like this, like a little pearly spot, mainly on the face. And I know Dr. Jackson is going to go over it and talk to you a little bit more about the symptoms. This one truly is the most common cancer of human beings. So about 4 million cases in the United States alone are being diagnosed. So I know Steve had many of these. So thank you for being here. One of the patients that I see very frequently. And we'll just go over how he feels about, how he detects it himself, and maybe he can talk a little bit about his experience soon. But let's go over the other very common type that also comes from the out of control growth of these cells that are on the very top layer. This one is called squamous cell carcinoma. And this one may be a little different than the basal, sometimes has sort of the crusty look to it on scale. And then moving on to the other type that is not as common as the other two we mentioned, but is considered the deadliest form of skin cancer. That one is melanoma. So there are some cells in the top layer of our skin that make the color or the pigment in the skin. They're called melanocytes. And if these cells go out of control, then they make melanoma. If melanoma is detected early, is highly treatable. However, it can be, unfortunately, a deadly cancer. So it's really important to detect melanoma. And I have here some of the features that can help us recognize melanoma. So I'll go over these because this can, for our audience at home and for anyone who has moles, that can be a guideline. So many of us have these dark moles, right? But then some stand out, and the ones that stand out, it's reasonable to check them. So these are the guidelines that American Academy of Dermatology put out there. For short, we call them ABCDEs of melanoma. And let's go over them. So A stands for asymmetry. So as you can see here, this mole looks that one half is unlike the other. C stands for color. So the moles that have multiple colors in them, they may need to be checked out. And you can see here, there's a bit of a pink, there's a bit of black, brown. And I think I forgot B, going the other direction. So going back to B stands for borders that are irregular and scalloped. So as you can see in this example. So going to D now, diameter is a factor we consider. So patients who have moles that are larger than 6 millimeters, which is roughly, the size of a pencil eraser. Those are the ones that if they have any of the other features, they may need to be checked. And finally, the most important one is E for evolving, meaning something that changes over time. So with that, I'm going to conclude the melanoma, but let's tell you a little bit about some other rare cancers, because going back to how the skin is constructed, many different cells are there. So any of the other residents of this garden can also grow, but these are rare. So something like cutaneous lymphoma comes from all the immune cells that travel to the skin. And then we have sarcomas and Merkel cell carcinomas. Even though these are rare, we can see them in the patients. Steve, for example, had one of these sarcomas also on the skin. So anything that grows and looks unusual on the skin, we may need to have it checked, and we'll have a little bit more for you as to what to look for. All right, so at this point, the question is, how do we prevent it? Who gets it, right? So mainly, the main cause of skin cancer is exposure to sun rays, the ultraviolet rays. And the best thing we can do is to protect skin from exposure to sun. So I have a couple of simple guidelines that I will go over them. But I just wanted to kind of bring Steve to the conversation, because I know that there was a lot of sun exposure, and you mentioned it. But maybe you can tell us a little bit more about what type of sun exposure you had, and share your experience with us.
Okay. Well, I grew up a few miles from the beach and was out on the beach at every opportunity through my entire childhood and adolescence. And after college, I spent probably another 30 years, most weekends and any vacation I could get at the beach, with most of it very little protection, very little. In later years, yes, ointments were available. I started using an umbrella, but that's much more recently.
And Steve, I think it's notable to mention that many of the cancers that you had were on the so-called sun-exposed areas of your body. So I've been treating your cancers and actually have a record of you since 2010 till today. And every year we had about 2 or 3 cancers, skin cancers, basal cell squamous, and they were mainly on, say, the face, the legs, and so on. So any areas that exposed to the sun, and this is really, where we see the direct relationship to the basal cell and squamous cell to exposure to sun. Let's now go back to my PowerPoint, and then I can tell you a little bit about what dermatologists recommend. What are the recommendations from the American Academy of Dermatology in terms of how we protect ourselves from sun? Pretty simple. So first of all, seek shade. So the sun rays are strongest between 10 and 2. And this is the time that you may want to stay indoors if you're very fair and a light skin individual, or you may want to seek shade. Okay. Now, wearing sun protective clothing is really important. So it's summertime, but this is the really great time to discuss this. So mainly lightweight, long sleeve shirt, pants, a hat, and sunglasses with UV protection. Look for clothing that had ultraviolet protection factor label. All right, sunscreen, really important. We need to apply it when we're under the sun, and a couple of things about the sunscreens that we should pay attention to. So we recommend a sunscreen that on the label has these 3 different components. The first one is broad spectrum. The rays of the sun have ultraviolets A and B, so we need to protect ourselves against both. SPF 30 or higher, and water resistance, or very water resistant. So these are the 3 components that you want to check on your sunscreen bottle, and then you want to use enough sunscreen on the skin and apply it often. So you need at least about the amount that fills a shot glass to cover all the exposed areas of the body. Use extra caution near water, snow, and sand. So it's not just a summer practice. winter, we need to do that. On cloudy days, we also need sunscreen. And finally, it's important to avoid tanning beds. The risk of tanning, the association of that with the skin cancer is established, and we do recommend self-tanning or spray tans, right? So how do we screen for skin cancer? So we don't recommend to bring everyone for skin cancer screening, but depending on the risks of the individual, they need to be seen. Now, anyone who's 35 and 70, between 35 and 75, with one or more of the risk factors that I'm going to review, needs to be seen by a dermatologist for something called total skin examination once a year. So someone who's light skin, blonde or red hair, or someone who has many freckles. Now, having said that, the skin cancers are more common in individuals with light skin, but they can be seen in individuals of all skin colors. So, and we'll talk about an example of specifically for our dark skin individuals and when they can be at risk for skin cancers coming up soon. So patients who have lots of moles, at least those who have more than 40 total moles, and those who have a history of sun damage. So Steve fits the criteria just by his light skin and the fact that he's had lots of exposure to sun. So severely sun damaged skin, if someone had blistering sunburns or in the past, and or anyone who had indoor tanning. Patients who have an immune system that is not fully functional, meaning if they take a medication to suppress their immune system, and this is where the caution to African American patients should be mentioned. So patients with dark skin who are, let's say, organ transplant recipients, their immune system is not fully functional, so they are not able to eliminate skin cancer perhaps as efficiently as someone who is not. And so they have the risk for skin cancer that they need to be checked. Those patients who have maybe taken or have HIV or taken biologic medications that suppresses their immune system. Now, if the patient has a history of skin cancer or melanoma, they also need to be checked. Or if they have someone in the family, one or more family members with melanoma, or if they're known mutation carriers. So these are the general guidelines for who has to come and see a dermatologist. But the general public can just easily look at their skin. Good news with skin cancer is we can see it. So check the spots. And I know Dr. Jackson is going to go over this in more detail, but looking at your skin goes a long way. Now, how do we look at our skin? Use a mirror, look into the corners, like some places like elbows, look at your feet between the toes, areas that you may not look, once a year or once every 6 months. Just have your, a friend or partner or yourself looking at the mirror and check your skin. You can look in the back of the neck or your scalp. And it's just good practice to take a look. And, maybe spot any of the A, B, C, D, E's that we discussed. If you see, changes in your moles, then it's time to perhaps, contact us and or either start with your primary care physician or see a dermatologist for something called full body skin exam. So when you come to our office, we will perform full body skin examination. So we'll have you go in a gown, and essentially we'll start with looking at different areas of your skin, starting from your face, your scalp, and going down basically to your trunk and your arms and your legs. So this is something that I do with Steve very commonly. Every 4 months, we'll do skin cancer screening. So I'm going to have Steve maybe talk us a little bit about what his experience is like when he comes for skin cancer screening.
Okay. Typically, I do self-examinations almost continuously, I mean, every few days, really. And if I see a problem, I'll pick up the phone or get on the website and we'll deal with it. But in the office, I get a thorough screening at every visit. As Dr. Nickbach said, we've been doing that now every 3 to 4 months. And I think it's really paid off. I sometimes find things which are nothing. And other times, my perception was on target. But it's really easy to stay on top of it if you pay attention. And I think that's what counts.
Thank you. So, Steve is one of our patients who, for whatever reason, has a higher chance of developing these skin cancers, but not every individual is the same. Let's say if you had a twin brother with the same skin complexion, right? He may not be as susceptible as you. So it's just, there are many factors that come to play. Yes, we can blame sun exposure, and we absolutely recommend staying away from sun and protecting, because that is really the most important thing we can do to prevent skin cancer. But different individuals have different risks. So for, we reviewed the risk factors for who needs to be seen or who needs to think about, at least setting up annual exams. For Steve, we need to do this more often just because of the fact that he's more likely to develop skin cancers. And then skin cancers screenings are important because we can catch the cancers early. So the treatment is much easier when we find them soon. Sometimes we can treat them right in the office, let's say with freezing. And that's something we do often. When you come, we pick some of the spots that look like they're precancerous, and we just get rid of them by spraying very cold liquid nitrogen on them. And we can talk about the importance of this is in terms of what happened during the pandemic. Steve, maybe you want to take us through your experience when you actually found the spots and we weren't able to do screening for you.
Well, there was a period when it wasn't possible to do screening, and that was during COVID. What I typically did was to take photographs and send them to Dr. Nickbach. And in a couple of cases, she was able to prescribe topical treatments, which had varying degrees of success, but at least got me through until I could visit again.
Yes, we did try that, but unfortunately, one of the cancers that we detected, we ended up having to do a more extensive procedure. So I think for us, it demonstrated the value of screening. But even for those who may not be able to make it to the office, telemedicine may be an option. Taking pictures and photos, and although visual exam and treatment in office is the best.
We have some questions coming in. I think someone is asking, like, can younger people, like people under 35, are they also at risk for skin cancer? Should they also consider getting like regular skin cancer checkups?
So that's an excellent question. They can get skin cancer. So we have many young individuals who've had, let's say, basal cell carcinoma in their 20s or perhaps younger, and melanomas can be diagnosed in younger patients. However, if you look at the general population, we do not recommend for these younger individuals to be seen annually or once a year by dermatologists to do preventive skin cancer screening, unless they have some of the risk factors that I mentioned. So why don't I actually share that screen back, because I think there was a lot of information on that with who needs to do screening. But let's say we have a young individual, who has lots of moles or who has a strong family history of skin cancer. Then I think it's reasonable for them to come to office and be screened. Pediatric populations, generally, we don't we don't recommend, again, unless there is a strong family history, there is a known mutation, for example, in the family, so on.
Thank you, Dr. Nigbart. And we also have another question asking about kind of like, I know this is the summertime, a lot of people may go to the beach or go just like play with water. Like, is there any suggestion on choosing sunscreen? Like, is usually like a higher SPF, like a better option to protect your skin?
Yes, so in general, the recommendation from the Academy of Dermatology is 30 and above. However, let's go back to our sunscreen slide. The thing, so the number, this so-called SPF, is an indicator of how much the sunscreen will extend your natural protection. So those individuals with lighter skin, they're more susceptible to, let's say, quickly develop redness or be burned by sun. So for them, this protection time is shorter. We need at least 30, but perhaps they need to go look into the higher numbers, maybe 70. Think about that. So making sure that, again, as we said, broad spectrum sunscreen is selected, and also think about the ingredients, and I don't have it mentioned here, but I can say to our audience, those sunscreens that have the so-called physical components in them, zinc oxide or titanium oxide, as opposed to the chemical. So the mineral shield sunscreens, the baby sunscreens, they usually have those physical components, zinc oxide and titanium oxide. So they may be, the words to look for on the back of your sunscreen bottle. But many of the sunscreens that are available in the US market, they're all tested and overall are good choices to select from.
Thank you, Dr. Nigbart. I think we'll wrap up your section. Thank you so much for sharing what is skin cancer and also the ways that you can protect your skin. We will moving on to Dr. Jackson. Could you please walk us through like how skin cancer is diagnosed and treated?
Yeah, sure. Thank you. So just like Dr. Nigbart, I made some visual aids to kind of talk us through this part of the conversation. So give me 1 minute while I share my screen. Okay, so Dr. Nigbart talked a lot about who should have screening and the different types of skin cancer. So you may have some idea of what skin cancers look like now, but not all of our patients present to us in clinic for just a general overall screening. Very often patients come to us with a spot or two that they're worried about. And I wanted to briefly highlight some of those symptoms that patients might come to us with whenever they're worried about a spot. So it's very important to remember that skin cancer can arise in either a new lesion or an existing lesion. So keep an eye on both the spots that you've had and on anything new that comes up. You want to keep an eye out for anything that is growing, anything that's changing, anything that is ulcerating, or anything that is bleeding. The other thing is sometimes patients come in with phrases that we as dermatologists recognize as concerning for skin cancer. And these are a patient who comes in and says, I hit this part of my shin a couple months ago and it just won't heal. And the other is more on the face. Patients will say, I've got this pimple, doc, and it just won't go away. So these are things that you should keep an eye out for. And I know there was a question about people less than 35, can they get skin cancer? Well, they certainly can get skin cancers. And even though we don't necessarily recommend that they come in for annual screening skin checks unless they have those risk factors that Dr. Nigbart went over, if they have any of these concerning symptoms in one of their lesions, they should definitely come into the dermatologist and get that checked out. And I just love this this ad by the American Academy of Dermatology for their Spot Skin Cancer campaign, because it reminds me of the Playful Pup in the Spot children's book series. So the main takeaway point is, if you see a spot on your skin and then you look down at some point in the future and it looks like that spot has changed, that should be a clue to see a board certified dermatologist and get that checked out. So I know that our panelists have, our cancer survivors have had skin cancers, and I'd love to hear what symptoms, you know, brought you in when you first were diagnosed with skin cancer. Or are there any things for you, Steve, that, you know, are the clues that bring you in to see Dr. Nickbach maybe ahead of your normal screening?
Well, yeah, there are. Something new that I haven't seen before is usually my tip-off that it should get looked at. I did have a tiny pimple that didn't go away, and seeing that phrase, you know, about pimple really brought it back, and that turned out to be the most serious thing I've had. But more typically, yeah, I have lots of keratoses that occasionally start changing slightly. They usually turn out not to be much of anything, but they're worth looking at, certainly, because there's always one that does. It covers a wide variety of things at this point, but you know, the key again to me is just staying on top of it.
How about you, Anne Marie? Do you want to tell us what symptoms brought you in for the first time, or just being persistent, maybe?
I was actually having a breast biopsy done, and while I was disrobing, the doctor looked at my arm, and I had a cyst on my arm, which had been there for years. And during that year, I had gone through a lot of stress, and it had started to change. It had started to itch, and it had started to grow. And it was to the point where I was very aware of it being there. So she looked at it and she said, that needs to be checked out now. And I kind of blew it off, like, I've had it for like, you know, years. It's fine. She said, no, get it checked now. And she kind of put the fear of God in me. Thank God she did. So, you know, it's always in the back of your head when it started to itch that there's something serious here. But I automatically went into denial, like, oh, it's nothing. It's nothing. I wish I had listened to that inner voice. It probably would have been caught a lot sooner. But anyway, that doctor probably saved my life. That's it.
Great. Thank you so much for sharing that. And, you know, I love that you brought up itching. As I was looking over my slides, I kind of for a second paused and was like, man, I wish I would have put itching on there, because itching is a very common symptom that brings patients in to have their spots checked by a dermatologist. Of course, I was thinking that at the last minute, so I didn't change anything, but I will do that in subsequent versions of this talk if I'm ever able to like talk about this again. I think itching is a really important symptom, so I'm glad you brought that up. All right, so let's go back to then talking about, you know, what happens when you come in and you have that spot, and what happens in your clinic visit. So your dermatologist will look at it. We call it visual inspection. We clinically are able to diagnose things sometimes just by looking at the skin. Other times we'll use a specialized tool, like in the picture over here, that's called a dermatoscope. That's basically a magnifying glass that has polarized and non-polarized light and lets us see a little bit deeper into the skin. And there are characteristic patterns that go along with some of those different skin cancer diagnoses that gives us an idea of whether this is something benign or something that could potentially be problematic for our patients. If we do have a high level of suspicion, we may recommend a biopsy for our patients, which is kind of what's depicted here in this middle image. after the biopsy, which is a really quick kind of in-office procedure, takes about 5 minutes, the skin gets sent to the pathologist who looks under the microscope and determines whether or not it is in fact a skin cancer. And the process of waiting for your results can be anywhere between 1 and 2 weeks. And I think that's really important to be aware of, that it can take some time to get those results back. So I want to stop sharing again, just to go back to our survivors and say, you know, the process of getting a biopsy, I often hear patients saying they were just too scared of the pain, right? They're always, the pain is something that is very aversive for people. And so I would love to know what your experience was with getting a biopsy. You know, did you have concerns? What was the experience like for you?
Is that for me?
Either of you guys, I'm sorry, I guess I should pick.
Now go ahead, Anne Marie, and then I'll talk.
It's completely painless. I had gone to the dermatologist who looked at the mark on my arm and thought it was a keloid, actually. And he took it off and he did the biopsy. That it was painless, and it was over in less than 5 minutes. It was a simple procedure. It did take about 3 weeks for the results to come back because he didn't believe them the first time they came back, and he had resubmitted them to be done again. And but for anyone who's fearing that this is going to hurt, it doesn't. It didn't. It's painless.
I would totally concur with that. Absolutely painless. A little bit of stick of anesthesia and then no pain whatever, and it takes a few minutes. It's the easiest thing in the world.
Great. I'm so glad that that was such a good experience for the both of you guys, because I do think that the fear of the procedure itself keeps some of our patients away, keeps patients from coming in sooner. So let's go back again. Okay. So then the next thing, once your dermatologist has an idea of what type of skin cancer that you have, they'll want to come up with a treatment plan. And I think it's really important to know that the risk of the cancer spreading often guides the treatment options that we have available. So certain cancers, like basal cell skin cancers, have a very low risk of spreading anywhere. They like to grow locally. They grow very slowly. So we can often treat these in a very different way than something that's higher risk, like a melanoma, which does have a propensity, if it gets deep enough, to go through the bloodstream and can cause a lot of systemic disease. And then kind of lying in between those are your squamous cell carcinomas, which can occasionally have more aggressive features. It really depends on a lot of things: the size of the lesion, its location, and the specific subtype of squamous cell carcinoma. So your doctor will better be able to classify those. But just in general, understand the concept that for our lower risk skin cancers, we have certain treatment options. And for higher risk skin cancers, sometimes we have other options that would be available to patients. And one thing that I think is really important to know is that most early skin cancers can be cured with a simple in-office procedure. So this doesn't have to be a big thing that you worry about forever. Now, there are, lesions that we catch later, or that do require more involved care. But for the majority of the skin cancers that we detect, when we detect them early, a simple in-office procedure will take care of them, and you won't have to worry anymore about that. So for our lower risk skin cancers specifically, one of the common procedures that we do in the office is something called electrodesiccation and curettage. In this technique, we take a circular blade and scrape away the skin cancers, and then use an electric needle to further destroy any cells that remain. It's very quick. It can be done in probably about 15 minutes. you're left with a little circle scar that heals in with just Vaseline and a bandage over the next 1 to 2 weeks. Also, another option for our lower risk skin cancers are topical creams. And these, there are specific indications for. We can't use them for all skin cancers, but for early skin cancers that are lower risk, we can use topical creams. These have to be applied by the patient at home for several weeks, and it varies by which indication we're treating as to how long you have to use these creams. Now, one thing to think about with the creams is that it's very much dependent on the patient's compliance and their ability to use the creams very regularly as to whether or not the skin cancer actually gets appropriately treated or adequately treated and goes away. And these creams can cause a lot of irritation and redness. And so sometimes patients don't want to deal with that irritation and redness for a long time, or they don't want to have to remember every day. And in those cases, another treatment might be a better option. But we do have this as a tool available to us for lower risk skin cancers. There are also surgical approaches that we can take care of. And this is getting into, we can use these for lower risk cancers, but we can also use them for intermediate and higher risk skin cancers. So these surgical approaches have an advantage, generally speaking, over ED&C or creams because the doctor can confirm that the skin cancer is out underneath the microscope. Whereas in the other ones, we just kind of assume it's all gone and then watch to make sure it doesn't come back. Now, in a standard excision, a doctor cuts out the lesion and a surrounding margin of healthy skin, and often these extra dog ears just to facilitate closing of the skin in a nice linear fashion. The tissue that comes out of that is sent to the pathology lab where the pathologist looks under the microscope to make sure that they think it's all gone. Now, Mohs surgery is a different type of surgical procedure, and it's used for skin cancers that arise in areas like this nose tip where there's just not a lot of extra skin around to close a wound. Or it's used for skin cancers that are larger or have a higher risk of recurrence. So the technique of Mohs surgery and why we like to use it in areas where we need to conserve tissue is because it allows for examination of the entire surgical margin. So the way that I like to think about this is like it's the liner of a Reese's Pieces cup. So this is what the skin cancer is cut out in a circular fashion. And the margin of the skin cancer is that liner, right? It's all that goes all the way around the skin cancer and all the way across the bottom of it. And so what your Mohs surgeon will do, with its Histotex help, is lay out the tissue so that they can examine and make sure that your entire margin is free of tumor that same day. And so this process looks at 100% of the surgical margin to make sure it's all gone so that they can reconstruct that area that same day for you. Now, in contrast with the standard excision, we compare this more often to something called bread loafing, where periodically the pathologist makes cuts in that tissue block and then looks at those cuts underneath the microscope. And the true margin in this scenario is likened to the crust of the bread. But it's basically like you can see the margin in one slice of bread, and then you skip a couple slices of bread and you check the margin in a few additional slices. So you don't actually look at all of the surgical margin, but you do get a very good idea from the multiple cuts of whether or not all of the skin cancer is out. So the standard excisions, these are performed as a relatively quick, about 30 to 45-minute procedure. They can be done in the office with local numbing medicine and a patient that's awake, or they can be taken into the operating room if they need to be done there. Generally, patients are closed up right away. And the sutures are left in place for about 1 to 2 weeks. And then the patient might have activity restrictions for a couple of weeks just to make sure that you get the best cosmetic outcome and healing from that surgery. But it's overall a pretty straightforward procedure. And, the cancer is, we can confirm the cancer is completely removed. Now, Mohs surgery, as I mentioned before, it's a very specialized procedure, and it's performed by a doctor who has advanced training. Usually it's a dermatologist, but has specific training in skin cancers, skin surgery, skin pathology, and also more complex reconstruction than just closing things in a line. Now, in Mohs surgery, the procedure is also done in office with an awake patient, but it can take a little bit longer, and I'm going to describe for you why that's the case. So in Mohs surgery, the skin cancer is removed layer by layer. So the doctor takes what they see as the skin cancer with a very narrow margin of surrounding skin, and then they process that the same day and look at it themselves under the microscope and make sure all the skin cancer is out. If the skin cancer is not all out, they have mapped it very precisely, and they go back only in the area where it was positive and take a little bit more. Once they're 100% sure that the skin cancer is all out, they design a reconstruction for that defect that's left after the skin cancer. And usually both the surgery and the reconstruction can be done in the same day, but it can take a longer time period because of this iterative nature, where the skin cancer is removed, it's examined under the microscope, potentially additional skin cancer needs to be taken, and then that has to be examined under the microscope. And then once we know it's all out, we can actually go back and close it up. But after, aside from the differences in the experience of the surgical day, usually the post-op is about the same. So patient will have sutures for about 1 to 2 weeks and activity restrictions for anywhere from 2 to 3 weeks. And then they can be assured that their skin cancer is completely removed. In terms of post-operatively, what happens or what could you expect? So generally with wound care, we recommend patients leave a pressure bandage on for 24 to 48 hours after their surgery to decrease the risk of bleeding. But after that, you take off that bandage, you wash your wound with like soap and water, and then cover it with Vaseline and a bandage. Most of the time, this only needs to be done for 2 weeks to 3 weeks. That's for sutured wounds. If a doctor does decide that it's in your best interest to leave a wound open and let it heal in on its own, which we do sometimes do at certain sites, sometimes you have to put that Vaseline and bandage for up to 2 months. And then it's really, I think, an important message to patients is that usually you have a good idea of how things are going to look at about 2 months after your surgery, but your scar will keep looking better and better over the subsequent year. And so most of what I've talked about so far is for local, lower to moderate risk skin cancers that can be cured with surgery alone. But for more aggressive or advanced skin cancers, additional tests for distant cancer may be ordered by your doctor. And occasionally for skin cancers that are caught at later stages, adjunctive or alternative treatments will need to be done. So we're going to have Dr. Sidor talk about that in just a minute. But before we move on to that, I thought we could ask our cancer survivors for a little bit more about their experiences with their surgeries and what their post-operative periods are.
I'll go first. I had surgery, and that is scary, because whenever anyone says you have cancer and you need surgery, you get scared. When they did the surgery, they took out 2 lymph nodes, and it didn't take long. It probably took about 2 hours, and I was home a couple hours later. Very little pain other than the suturing, which was extensive because they had cut a big piece out. But when I went back, I got the good news that the lymph nodes were clear, and they believed they got everything. So I couldn't understand why my doctor had recommended me to go for immunotherapy, because in my mind, You got it all out. You cut it. It's gone. It's done. I wanted to put it in the past and be done with it. I was wrong, dead wrong. So I went to Jefferson and had the immunotherapy done, which was, I had no problem with it. I had no reaction to it. I was very lucky, great people there. But the nicest part about it was now I had a team. I had a team of people looking out for me. Instead of feeling alone, I had people I could call or text at any time. And that was the greatest gift of knowledge and knowing that, you know, someone was there for me if I had a question or it didn't feel right or anything that went wrong. I could call, I could text my girl who did the questioning for the immunotherapy, and Kathleen was her name, and she'd get back to me within 10 minutes. And they wanted to know everything. If I took an aspirin, if my doctor put me on medication for my stomach, everything. They kept track of everything. So I can highly recommend. I'm very grateful that I had the opportunity to go into that clinical study and have the immunotherapy done. So that was my experience.
Okay. My experience has been with much more minor things, but I've had everything from freezing of precancers and early stage cancer to excisions, Mohs surgery, ointment treatments, and I had a laser as well, and a procedure called blue light, where ointment or something is painted on my entire scalp, and I sit under this blue light for a period of time, which really did wonders, clearing up a lot of things. But none of it has been difficult. None of it's been painful. And everything has healed really well. I noticed there was a question about scarring, and in some cases, absolutely none. Others so minimal, you'd really have to work hard to find it. And the most severe surgery I had with a wound that was left open, where I did have to apply Vaseline and keep it bandaged for a few months, ended up healing so completely that it's completely unnoticeable at this point. So, the results, the after effects have been virtually not at all.
Thank you so much.
Great. I'm so glad that you had that experience. And Anne-Marie, thank you so much for sharing your experience. Now, you had one of those more advanced skin cancers that Dr. Cedar is going to talk a little bit more about. So your situation was a little bit more unique in that regard, and that it required that more complex care. And I'm really glad, Steve, that you brought up the blue light therapy and the freezing, because those are things that we do in the office for our patients who are at higher risk of developing skin cancer because of precancerous changes that we see on their skin, to kind of try to deter them from getting a skin cancer at all. And I didn't talk about that because most of what we were talking about was directed towards the skin cancers themselves, but definitely precancers are a big thing and very common when patients come in for a spot check. That's what they actually have. And if we can treat them at that stage, we can really prevent them from even going on to becoming a skin cancer, where a patient would have to go through any of these procedures at all. Now, I saw there's a question about scarring, and I think that's a great question too, because I do think that part of the reason why patients stay away from coming in to get care even after they have a skin cancer is that they're afraid of what it's going to look like afterwards, or the scars. So you know, my, I guess, approach towards scarring is that anytime we cut the skin, you're going to have a scar. It's just a guaranteed. It's a part of how skin heals, at least with the knowledge that we have now. But my goal as the surgeon is that your scar is so imperceptible that someone at a conversational distance wouldn't really notice it. Their eyes wouldn't be drawn to it. And so that is what I try to do for my patients. And I also try to think about, like, if this were on me, what scar would I want? Because I understand that I have to have a scar, but what scar would I want? And so that's how I treat all of my patients, is with those two principles in mind.
Thank you, Dr. Jackson. And I think we learned a lot about the surgical components related to the skin cancer. And Anne-Marie, thank you for sharing your experience. I think it's a nice transition for like some of the patient may need beyond just the surgical procedures. So Dr. Cedar, would you, as a medical oncologist, could you like elaborate on like what are the treatments or additional imaging that may needed for patient like Anne-Marie? Maybe like first tell us like who need to see you.
Absolutely. And so not everyone needs to see a medical oncologist, but patients with what we consider advanced skin cancers or high-risk skin cancers do end up seeing a medical oncologist. But your dermatologist or your surgeons will usually be the ones to recommend that you go ahead and see a medical oncologist. And so typically, like the in situ cancers, skin cancers that are very superficial, very, very early, don't have to see a medical oncologist. It's usually the ones that, the skin cancers that are a little bit deeper or larger, the melanomas that are a little bit more high risk for spreading, that usually end up seeing the medical oncologist. And as a medical oncologist, my role is to help determine if the skin cancer has spread, and if it has, to decide on the best treatment for you. And also, if you don't have disease that has spread, how to monitor for cancer spreading going forward, and if there's any way to prevent that if you're at high risk for recurrence. And so not everyone needs imaging. Very early stage cancers may not need any imaging, whereas some other more advanced cancers may need something as basic as a chest X-ray or a full head to toe imaging like a PET scan. And so that's something that you would discuss with your medical oncologist. And in terms of, sorry, I don't have slides, but I do have some notes just so that I cover everything. And in terms of a lymph node biopsy that Anne-Marie had, so specifically for melanoma, because they do have a higher risk of spreading, some melanomas, we do recommend that you get something called a sentinel lymph node biopsy. So that is a surgical procedure where they check the lymph node that the melanoma is draining to or it's closest to. And so we talk about lymph nodes a lot, but for a lot of people, they don't really understand what a lymph node is or what the lymph node system does. And so what I usually tell my patients is that your immune cells or your infection fighting cells travel throughout your body using a highway system called the lymphatic system. And on the highway system, you have rest stops called lymph nodes. And so your immune cells travel through the lymphatic system, start up at the lymph nodes, and then move on. But cancer cells, specifically melanoma cells, are very smart in that they hijack the highway system, get on the highway system to the rest stop, and then travel to other parts of your body. And so for some melanomas that are higher risk, based on underneath the microscope, if it looks aggressive, if it looks pretty deep or large, then we do recommend that a surgeon do what we call a sentinel lymph node biopsy. And so usually in the OR, they will inject a tracer into where your melanoma, the skin melanoma was, and then they'll follow it to the closest lymph node. And then the surgeon will remove a couple lymph nodes that the tracer went to, and then they'll send it off to the pathology lab, and they'll take a look under the microscope to see if there's any microscopic cancer cells that are already starting to spread. And so in melanoma specifically, when we stage cancers, stage 1 and 2 are if it's still within the skin. Stage 3 is if it's gone to a lymph node, and then stage 4 is if it's spread kind of throughout the body. And so talking about treatment, it depends on what your final stage of melanoma was. If you are a stage 3 melanoma, meaning your lymph nodes did have some microscopic cancer cells in it. We know that yes, your lymph nodes have been removed, your melanoma on the skin has been removed, you are cured of your melanoma. But we know that if it started to travel to the lymph nodes, the likelihood of the melanoma coming back is high. And so now we have a therapy called immunotherapy that we usually offer for 1 year. It's an IV therapy about once a month or every 6 weeks for a year to try to reduce that risk of your cancer coming back. And so that is standard of care. And I'll talk a little bit more about what immunotherapy is. Now, stage 2 disease, if it's a melanoma that's still within the skin, but it's gotten pretty deep or it looks pretty ugly, such as the case of Anne-Marie, we initially, about a year ago, we didn't have any therapy to offer, but we knew that some stage 2s were high risk. And so we started a clinical trial looking at for stage 2B, 2C patients, so higher risk stage 2 patients, maybe we should be also giving 1 year of immunotherapy. And so that's the clinical trial that Anne-Marie was on, and we'll talk a little bit more about that trial. But now that is actually an FDA-approved therapy for certain stage 2B, 2C patients. And so for stage 2B, 2C, and 3, you may need 1 year of additional therapy called adjuvant therapy to try to reduce the risk of your cancer coming back. And if you have stage 4 disease, or if the disease has already started to spread, then you will also be recommended immunotherapy or some targeted therapy potentially. And so I just want to step back and say, wait, you haven't talked about chemotherapy. And so I know a lot of patients or a lot of people out there are terrified at the idea of getting chemotherapy. They don't want to go see a medical oncologist because they know they don't want chemotherapy. And so I'm happy to say that in most skin cancers, melanoma included, we very rarely use chemotherapy now. We have a therapy that I mentioned, immunotherapy, which is a different category of medication. It works differently and the side effects are different. And so you're not getting chemotherapy where you're losing your hair and you're nauseous and you feel terrible and you've seen all these movies about it. It's different. Immunotherapy is a medication that helps your immune system find the cancer and to help attack it. And so it tends to be much more tolerable than chemotherapy, as Anne-Marie can tell you, although it does have kind of a different side effect profile that we look out for. And so that's a little bit on therapies. And then I want to jump to clinical trials since Anne-Marie had been on one. Clinical trials, what are they? They are research studies investigating a new treatment, new drug or new imaging or something new that they're trying to investigate the safety and the effectiveness of it. And so there's different phases of a clinical trial. Phase 1 is the earliest clinical trial where they're looking at specifically how safe the treatment is. It's usually in a small population of patients. And if it passes the phase 1, it seems to be safe, then they move on to a phase 2 clinical trial where they enroll more patients. And now they're specifically looking at how effective the drug is. And then if it looks promising in phase 2, and they're also looking at what dose of the drug may be the most effective. And so if it looks good in phase 2, then they move on and open a phase 3 clinical trial where they're now enrolling a lot more patients to try to prove that, yes, this drug is safe and also effective. And so those are the first 3 phases of the clinical trial. These clinical trials follow a very strict plan. It's a written protocol plan that lines out who should be on the trial, what treatments will they get, what imaging, how are they going to be followed, and all of these protocol and plans are reviewed by the institution, the institutional review board, to make sure that they're safe and ethical. And so some people may be worried about, I don't want to be a guinea pig, I don't want to be on a clinical trial, but clinical trials are a very controlled environment. You have a lot of people looking after you on the clinical trial. And all of the drugs that we use now for advanced skin cancer, advanced melanoma, the immunotherapy drugs, they all went through clinical trials. All of these drugs were tested through clinical trials. And so they're very important in order to figure out what is effective, and the best way to give these drugs. And so thank you, Anne-Marie, for participating in that clinical trial. Immunotherapy is now approved for stage 2B, 2C patients, thanks to patients like yourself who enrolled on these clinical trials. And so I want to pause there and kind of open it up to Anne-Marie. If you could just tell us a little bit more about your experience on what it was, how did you hear about the clinical trial? What was it like starting on it, being on it?
My surgeon had recommended the clinical trial. And so I traveled up to Jefferson to speak to the doctor. It was Dr. Wilson at the time, I believe. And I was very hesitant at first. I had diabetes in my family, and I was told right up front that one of the precautionary things is they're checking to make sure that the drug do not attack your pancreas. And my mother was diabetic. My sister is hypoglycemic. So, and I'm overweight. And I thought, well, she was going to fall eventually. So at first I said, no, I don't want to do this. And gave it a lot of thought, went back to my the surgeon, who was not too thrilled with my decision. And he said, let me lay it on the table. Do you want to be treated for cancer, or do you want to be treated for diabetes? It's that simple. And I was like, you know what, you're right. So that was the best decision I made, because they gave me the necessary confidence that I was going to beat this thing and it wasn't going to beat me. And going through immunotherapy, like I had stated before, there are so many people looking out for me. It wasn't like, you feel like a guinea pig. At first, that's the thought that comes to your mind. But I said, it's not a blind study, right? How to make sure it wasn't a blind study. He's like, no, you're going to get the medicine. But there are so many people looking out for every little effect that I went through, that I felt so safe and so looked after, that it was one of the best things I could have done for myself. So no pain, no nothing. That was it.
Thank you for sharing, Anne-Marie. And I should have explained the side effects of immunotherapy, because I think that comes up a lot. And so the way I explain it to patients is that you have these immune cells, these infection-fighting, cancer-fighting cells, but they're not able to properly kill the cancer. And why is that? And that's because the cancer cells pretend that they're a normal cell. So your normal cells in your body have a way to tell your immune system that they're a civilian, that they're normal cells. Please don't attack me. And so they have these proteins on the surface, these receptors on the surface that tell the immune cells, I'm normal. So the cancer cells are smart, and they start to pretend to be a normal cell, putting out these proteins and receptors that say, I'm a normal cell, don't attack me. And so these immunotherapy drugs essentially strips the cancer cells, the normal cell cloak away from the cancer cell, so that now the cancer cells look like a cancer cell. And so then the immune cells can now attack your cancer cell. But the side effects are related to that, because you're now taking down the normal cell cloak from the cancer cells, but also the normal cells may also no longer look like normal cells. Your immune cells can accidentally attack your own body, and that's called autoimmune. And it's hard to predict for each person getting immunotherapy what part of your body may get accidentally attacked. We can tell you kind of the most common things, like you may get a rash, or you may have some thyroid issues, some diarrhea, but essentially any organ in your body accidentally could get attacked. And so one of that is including your pancreas. If your pancreas is accidentally attacked, you can develop diabetes. Now that is one of the rare organs that gets attacked, but obviously we have to tell you all of them. And so I think that's a legitimate concern that you had. I'm glad that you didn't have any side effects from the immunotherapy. And I will say a lot of patients with just one immunotherapy drug tolerate it very well.
And Dr. Sitter, there's a quick question about how long do clinical trials typically take? And if they are interested in being enrolled in clinical trial, do they just talk to their doctors? Is there other way they can find that information?
Yeah, so Clinical trials, how long do they take? It really depends on the clinical trial. For Anne-Marie, it was specifically a clinical trial looking at a drug for 1 year, whereas some other clinical trials, it'll be a drug for longer than that. So it really is dependent on the clinical trial. Where you can find clinical trial information, maybe we can post it on the Facebook Live page, but there is a clinical trial website on Jefferson that Jefferson has that you can look through clinical trials specifically for your type of cancer. But I think that your doctor, your medical oncologist, or your doctor, whoever you're seeing, would be a good person to start out with to see if there's any clinical trials that would be available to you.
Okay, thank you, Dr. Cedar. And for Anne-Marie, thank you so much for sharing your experience. Just quickly, I think one question for you is like, for your whole experience, like getting treatment and everything, do you think it has changed your view about cancer? I remember early in the conversation, you sort of mentioned cancer could be very scary. Like throughout your experience, like, is that change how you view about cancer?
Definitely. 3 years ago, it felt like a death sentence. And now I realize it's, highly curable in a lot of cases. And it is just a matter of being precautious. And I get scanned twice a year and a PET scan once a year. And that's probably, I don't know how long that'll go on. I think I was told 5 years. But yeah, it has changed. You learn to live with it. And you learn to realize that something can happen in the flash of an eye. It doesn't necessarily have to be cancer. So it's not as scary as it once was when you first. But I think that's something that you have to work through in your own head. You have to reach those certain stages where you learn to live with it and take care of yourself and do whatever you need to do to keep, the threat of reoccurrence down to a minimum, as in, staying out of the sun, or like I use 100 block sunscreen. I carry it in my car because it's my left arm that had the cancer. And when you're sitting in traffic at 4 o'clock in the afternoon and that sun is beating in the window, you're like, ow, and I'm spraying my arm. So you learn to live with it. And that does come in time.
That's awesome. And I think as a lot of people live with cancer nowadays, it's also important there are a lot of support and resources out there besides just like the support they receive from hospitals or the medical system. We're very fortunate to have Ms. Kelly Harris here. Can you share with us a little bit more about kind of like the resources or service your organization provides to cancer patients?
Sure. Well, let me start off by saying that many people, when they're diagnosed with cancer, report increased stress, anxiety, and fear because they've never been through this experience. And those emotions oftentimes focus on issues like, how do I talk to my kids? How do I talk to my family? What does this mean for my ability to work? How does this affect my finances? Well, am I going to meet people that are going through the same experience? And there are so many resources that are available to people in addition to excellent medical care. And I think the first thing I'd like to say is I always encourage people not to be afraid to ask for help. It does not mean that you're a weaker person or that you have less ability to manage your cancer treatment and your journey into survivorship, but it's a lot to handle. And so our organization provides a series of ongoing support groups. We provide individual counseling. We provide educational workshops. We provide mind-body programs. And we do that at no cost to the patient because we don't want there to be any barriers for the patients to participate in those. In addition, at hospitals, there are social workers, there are nurse navigators that can help patients identify resources that they may need as they go through their cancer journey. And I think, when you start looking and talking to people who are going through the same situation, you really can find a huge amount of support that can help you in a variety of different ways.
Thank you. Thank you, Kelly. And for our Facebook Live today, we are having a conversation about cancer, and we want to talk about like recovery research and reducing your risk. And the research is a very big component when it's coming to cancer. And Dr. Nick Bark, like early in this our conversation today, you mentioned about your expertise in cancer research. Could you also just briefly talk about what is your research and how is your research maybe advancing our understanding about skin cancer?
Of course. So my laboratory is one of the many at Thomas Jefferson University's Sidney Kimmel Cancer Center that focuses on skin cancer. We talked about some of the, the types of the skin cancer that are easily treated. But then we have advanced cases such as, melanomas. Not everyone is going to be like Anne-Marie, who is cancer-free. Unfortunately, some of our patients actually die. We have some of the rare cancers are talked about, such as cutaneous lymphomas, Merkel cell, and others. We still need to find better treatments for them. My lab and other labs here are focused on finding new treatments, finding why some of the skin cancers are resistant to treatment. And the focus of my research specifically is on cutaneous lymphomas and finding out why that skin environment, and I did that analogy earlier, like this garden that has all of these different components to it. That's what we call microenvironment. So how does this microenvironment promote the weeds or the cancer cells to grow? And how we can tweak it to prevent the cancer from growing further.
Thank you, Dr. Nick Bart. As we are getting closer to the end of today's session, we do want to have the opportunity for each one of our panelists to share maybe like a key message you really want our audience to take home with. Maybe we'll start with our cancer survivors like Anne-Marie or Steve. Maybe one of you would like to start.
Okay. Well, no, go ahead, Anne-Marie.
I found a wonderful resource in my local YMCA. They have a program called Livestrong at no charge to you or for a whole year. And their theory is to get your body as strong as it can possibly be. You are with other cancer patients who are in various degrees of fitness, but the camaraderie along with the physical workout and the benefits of the cost benefits of that were amazing. That program is offered in every YMCA at no cost to any patient. And the whole year is absolutely free to you. And the following year is offered at half price. And I think it's a underutilized program that most of the people I have spoken to who have had cancer were unaware of. So I just that was one of the components that I used. It was nice to sit down with fellow cancer survivors and who are going through a lot of the same things that I was going through.
That's awesome. Stay active and also you find your support network.
Correct.
How about you, Steve?
Well, firstly, I would say to be sensible and use caution when you're out in the sun. Use sunblock, try to stay in the shade, use common sense. And it's very easy to think you're invincible and just lie out in the sun. Suntans look great, but skin cancer doesn't. So it's well worth precaution. And secondly, do self-screening. And, once you reach an appropriate age for professional screening, do it. Make sure you do it. Just as you go to the dentist every 6 months and get your teeth checked, there's no reason you shouldn't get your skin checked as well. And it's the best thing you can do for yourself.
That's awesome. Thank you, Steve. Kelly, would you like to share your take-home message? And I think someone did asking about like how they can get in touch with the cancer support community organization.
Sure. Let me say, don't be afraid to ask for help. You're not alone. And there are resources out there for just about everything that you could need. So you can reach us through our website, www.cancersupportphiladelphia.org.
Thank you, Kelly. Dr. Cedar, would you like to share your message?
Sure. And so I just want to echo kind of what everyone else said, but detecting skin cancer early is important. And so skin cancer prevention is important. Going to see a dermatologist when you suspect something is important. And then if you do need to see a medical oncologist because you are at higher risk, there are treatment options. And like Anne-Marie had mentioned, we work as a team. And so we work with your dermatologists, your surgeons, and then we make sure we take good care of you.
Thank you. And Dr. Jackson?
Sure. My message was very similar to the other messages in the sense that, I don't want you to delay coming to see us for any reason. I hope that our cancer survivors have kind of reassured you that for the most of the skin cancers, if we catch them early, it's really not a big to-do to take care of that skin cancer if we catch it early. When we catch it early, I'm also able to give you the prettiest scar. So those are my favorite cases to work on because my patients tend to be even happier when they have a smaller, less noticeable scar. So, don't delay coming in to see us when you have that spot that you're worried about. It's really only going to be to your benefit to get that diagnosed earlier and treated sooner.
Dr. Nigbart?
Same here. I just wanted to echo everyone. Maybe for our audience to say one more time, what is on the skin is easy to diagnose. So you can see it visually, you can feel it, and we just detect by looking at it. So it is so easy to detect these skin cancers early and prevent unnecessary procedures in the future to prevent advanced cancers, to prevent chemo or systemic therapy and eventually death. So if you spot something on the skin, find a physician or a dermatologist to take a look at it.
Awesome. Thank you, everyone. I think our message is very loud and clear. I think getting screening is very, very important. We actually, my colleague will also share some resources, the Sidney Kimmel Cancer Center that is provided to not only our patient population, but we also have some screening events that is open to the community. So thank you so much for joining us today. So this is the second Facebook Live event for the conversation about cancer, the recovery, research, and reducing your risk. And this is hosted by the Sidney Kimmel Cancer Center. We hope that you'll find today's session that is helpful for you and your family. So you can follow us on our Facebook for any future live events. And if you have any suggestions or comments for our future events, you can also either leave a message on Facebook or email us at skccoutreach@jefferson.edu. And now you have the on the screen, you can see our the Sidney Kimmel Cancer Center, Cancer Support and Welcome Center that is also open to cancer patients and families beyond the ones that are seeking care at Jefferson. And our mobile screening van, there's a contact information with the phone number and email address. And I believe Dr. Nigbart is also running some skin cancer community screening events. Dr. Nigbart, would you like to share either like a phone number or that future event?
Yes, so we do work with the Cancer Center through the mobile screening van program, and the information about that is what you presented, and the schedule is out there. But I also wanted to share the phone number for patients or for those who, we talked about, if you see something, call a dermatologist. So here's the number. This is for the Jefferson dermatology practice, 215-955-6680. And we should be able to match you with one of our dermatologists or nurse practitioners for a full body skin exam or just a check of the lesion of concern.
Awesome. Thank you so much. And thank you. We will make sure this Facebook Live recording will also be available on our Facebook page. So feel free to share with your friends or families. I think we conveyed a lot of important message during our session today. And thank you so much for our amazing panelists for spending your time on today's session. Thank you so much for watching, and looking forward to see you again in our future event. Thank you. Have a good day.
Thank you.